Hi, everybody. Thank you so much for joining us. We will give just a few seconds here for folks to continue joining. All right, it looks like that's slowed down a bit, so why don't we get started? Welcome, everybody, and thank you so much for joining us for this discussion around compassionate overdose response hosted by Harm Reduction Therapeutics and Health Management Associates, or HMA. We're really glad to have you here today. My name is Margot Swift, and I'm part of the HMA team that provides harm reduction, consulting, and strategic support to Harm Reduction Therapeutics. A quick note before we get into things, please feel free to share your questions using the Zoom Q&A feature. We will do a combination of answering them in writing as we go through, and then we also hope to have some time at the end for discussion and to verbally respond to some Q&As. Here is a brief look at today's speakers for the session. We have Michael and Van, representatives from Harm Reduction Therapeutics, the maker of RiVive 3 milligram naloxone spray. We have representatives from 3 harm reduction organizations in Pennsylvania who will be sharing their insights and experiences with compassionate overdose response. And Nicole and I are representing Health Management Associates. I mentioned we provide support to the HRT team. Next slide, please. And here is a brief look at how our session will flow. So we'll start with Michael providing an overview of HRT, RiVive, and HRT's partnership with Remedy Alliance. Then Nicole will share some key findings from interviews the team conducted to learn more about community perceptions of naloxone and overdose. And then we'll have a panel discussion with Michael, Carlos, Sean, and Charlie, moderated by Van, about what compassionate overdose response looks like in action. And hopefully, like I mentioned, some time for Q&A at the end. Before we move on, I want to take a moment to thank all of today's speakers for being here. Thanks to the organizations who hosted the team and the community members who shared their input and experiences for the community feedback report that Nicole is going to talk about. And again, thanks to all of you for joining us today. And with that, to kick things off, I will introduce Dr. Michael Huffer, the co-founder and CEO of Harm Reduction Therapeutics.
Oh, thanks so much, Margot. It's a real pleasure to be here with you. If you've not heard our origin story, I'm going to give you a very brief version of it so we can get to the meat of the conversation today, which is Harm Reduction Therapeutics is unusual in a number of respects. One, we're a nonprofit. We're a 501c3 nonprofit pharmaceutical company. We exist today precisely because of an unmet need we saw 8 years ago now. I was at a conference with a colleague in 2017, and the FDA was begging pharmaceutical companies in the audience to bring forward an over-the-counter switch for a naloxone product. And thought that sounded like a great idea as deaths were skyrocketing. And so initially, we had reached out to those companies to see if we could help them switch their prescription products to over the counter. And without exception, we were told that they had no intention of doing that. And so, born of that frustration and that enormously large unmet need, we formed Harm Reduction Therapeutics with a single goal, which is to bring a low cost over the counter naloxone product and make it available at everyone across the US. I met someone literally just yesterday who had spent years in the Obama White House, and he shared with me a tool that they had at the time to kind of dream big dreams from a policy perspective. And that tool was, imagine that you were given a magic laptop, and any press release that you wrote on that laptop would actually come to fruition. If that was actually the case, like what press release would you write to kind of change policy in the US? I thought that was a very interesting intellectual exercise. But I'll tell you that back in 2017, the press release I would have written was exactly the one that we've subsequently released in late 2024 when we got FDA approval for 3 milligram RiVive. our goals wasn't just to get our product approved, it was really to make sure the entire pharmaceutical industry switched its position and transitioned those prescription products to over the counter. So in 2017, Narcan was $140 for a twin pack, had been stuck as prescription status for years, despite people begging them to take it over the counter. And in thanks in part to our work at Harm Reduction Therapeutics, filing an over-the-counter application for RiVive, those prices have now plummeted. Now most products are kind of in the mid $30 price range or so. And now at least over-the-counter intranasal naloxone is widely available. I'll also just say that when we formed Harm Reduction Therapeutics, we wanted to kind of pay it forward business model so that not only are we nonprofit and tax exempt, it's also the case that we give away as much as we can for free through our colleagues at Remedy Alliance. And so at least 10% of what we make. So basically, as you buy more RiVive, 10% of the cost of RiVive goes to ensure that at least 10% is given away for free. And the extent to which we're successful in other fundraising, if it were up to us, we'd give it all away for free. But ultimately, it does cost money. We have to pay contractors to do this for us. And I guess the other thing I'll say is Harm Reduction Therapeutics is unusual in a couple of respects. One, we're a nonprofit. And two, with Van and I on the call, you have 40% of Harm Reduction Therapeutics on the call. We are an extraordinarily small pharmaceutical company. So we say we're a pharmaceutical company, it's 5 people, right? But we heavily rely on partners and colleagues to both help with the manufacture, but critically the distribution of RiVive. Next slide. I'll just step back for a moment and say we chose 3 milligrams for our product, first and foremost because of input I received from colleagues, actually, this was years ago now at Prevention Point Pittsburgh, had really pointed me toward the need from the harm reduction community for a lower dose intranasal naloxone. So kind of armed with that input from harm reductionists, we met with the FDA. The FDA had a number of concerns about a 2 milligram spray, and so we ended up going with a 3 milligram spray. I'll also just note, because sometimes we get questions about safety and efficacy, the data is very clear. 3 milligrams of naloxone in RiVive is both sufficient to reduce opioid-based overdoses and is also safe. And the FDA threshold for approval of RiVive was identical to that of Narcan. We were compared to the exact same intramuscular naloxone comparator in our pivotal PK trial as Narcan. So the approval pathway was the same, and thrilled to be able to support the harm reduction community with RiVive. And on the next slide, I'll say, critical as a force multiplier is Remedy Alliance. I mean, they, one, have been instrumental from the very start of harm reduction therapeutics. And two, ultimately, it is those relationships that they have with you all distributing naloxone that really is this enormous force multiplier, so that we're manufacturing RiVive and that they're able to get it really across the country to communities and organizations that need it. With that, I'm going to turn it back over to Margot.
Thanks so much, Michael. Next, Nicole will share a little bit of information about HRT's 2025 Community Feedback Report. In order to save as much time as possible for the panel discussion, this is going to be fairly brief, and there's a lot of great information in the report. So if you're interested in reading it in its entirety, you can access it, the report, using the QR code that's on the screen right now, and I'll also share a link to the report in the chat in just a moment.
Thanks, Margot. Hi, everybody. I'm Nicole. A core tenet of harm reduction is centering the voices of people who use drugs. So for the second year, HRT has engaged people who use drugs through interviews about community overdose experiences and perceptions of naloxone dosing to inform their work. Next slide, please. So why did we choose Pennsylvania? We decided to do interviews in Pittsburgh and Pennsylvania, and we conducted 19 interviews with people who use drugs, who are at least 18 years old, and many of whom reported being highly confident in their overdose responsibilities, reflecting substantial lived experience responding to overdose. We were hosted by two nonprofit community-based harm reduction programs to conduct these interviews, including Punks with Lunch, which is a volunteer-run collective that shares free food and harm reduction supplies. And the HRT team was really excited to join South Philly Punks with Lunch for their distribution event, while Aaron, Russell, and I conducted interviews, as you can see on the slide. And the other host site was Prevention Point Pittsburgh, whose mission is to promote and advocate for harm reduction. They provide safe supplies, case management, and overdose prevention services across Pittsburgh. But both of these organizations do a lot more than what I just described. So I encourage you to visit their websites to learn more. Next slide, please. So what did we learn from these interviews? The first theme the interviews revealed is that there is a growing preference for RiVive among people who use drugs because it works to restore breathing and reduce unnecessary suffering from precipitated withdrawal experiences, making overdose response more manageable for both the survivor and the responder. One participant said, "The low doses, you can always add on top of the lower one. When it's high, you can't keep going. I think lower dose is better." Next slide. The second theme of the report is that education and experience can change post-overdose expectations. Many people expect naloxone to cause severe sickness due to repeated prior experiences with precipitated withdrawal. However, interviews showed that baseline education about dose and recovery can change those expectations. One participant said, "I don't know that there were different milligrams either. Like the lower the dose, the less chance of precip. I don't think that people know about all that. They just think naloxone spray saves someone's life." Ultimately, participants emphasized the need for more overdose response education on topics including dosing, what to expect after reversal, and Good Samaritan protections. This information would help reduce fear and support safer, more compassionate experiences. Next slide. And lastly, participants consistently emphasize that effective overdose response should be both life-saving and compassionate. 100% of participants who were comfortable administering naloxone prioritized effective care and a compassionate approach, minimizing withdrawal while treating people with dignity. Compassionate overdose response meant staying calm, being present and supportive, explaining what happened, and being educated and informed on how to recognize signs of an overdose. Next slide. So the 2025 Community Engagement Report confirms that effective overdose response combines evidence with compassion. Key recommendations to HRT include promoting compassionate response, expanding education for people who use drugs, and increasing availability of overdose response kits. In conclusion, real-world experiences in this report show that RiVive saves lives. 3 milligrams of intranasal naloxone is the right dose, and an overdose response does not need to be destabilizing to be effective. And again, the full report can be found on HRT's website. Thank you.
Thanks, Nicole. And next, I am pleased to turn it over to Van Asher, HRT's harm reduction specialist, to moderate our panel discussion on compassionate overdose response. Just a reminder for folks, if you have questions about anything we've presented so far or questions for any of the panelists, please feel free to put them in the Q&A within Zoom, and we will make sure they get answered. Thanks, Van.
Howdy. Thank you, Margot, and thank you, everyone. I just want to say add on to one thing that Michael had said before we jump in, which is, and for those of you who know me, I've been in harm reduction a really long time, and someone who's actually on this call had reached out to me and asked if I'd work with a pharma company, and I was like, "Have you met me?" And they told me their story, and it really appealed to me because they were like the Davids to the Goliath of big pharma, and I'm all about that. And on that same note, kind of what Nicole was saying, like, really, that's what harm reduction is. Like, we know what is best for like those of us who use drugs and those of us who used to. and how to do it. And we're constantly fighting like the machine. So it's their values really aligned with mine. And, I'm really honored to be doing this. I pretty much know most of the people on here, and I'm very excited to hear from you. So I'm going to ask you all to share your name, your pronouns if you choose, your title, your org, and just give me like a sentence that kind of lets you know what brought you into this work. I know for me, it was during the HIV epidemic, and there were 5 groups of people that they said were the throwaway class, and there was a lot of interlap. People who are unhoused, people who sold sex for drugs or money, people who injected, people of color of low income, and men who had sex with men. And I've fallen into 3 of those 5 categories at different points. And it bothered me enough that a group of people that never met me said it would be okay if I died in 6 months to 2 years when HIV was still considered a fatal illness. And so this work was the best possible screw you I could come up with towards a government that wanted me dead, was keeping myself and my friends alive and healthy. And that hasn't changed because I'm still angry. I'm not one of the like keep calm and carry on folk. And I don't believe the people that you're going to hear from now are either. So I'm going to start with Carlos and Sean. Can you introduce yourselves, please?
Hi, my name is Carlos Del Valle out of Prevention Point, Philadelphia. I'm a community engagement coordinator with the emphasis in overdose prevention. Um, I work here with Sean Westfall. I've been doing work here at Prevention Point going on 8 years now, and I have personal experiences in this field with family and myself, and I continue to advocate for those who are still out here on the streets.
Thank you, Carlos. Hi, everybody. My name is Sean Westfall. I use he, him pronouns. I'm the overdose prevention and harm reduction coordinator here at Prevention Point, Philadelphia. Doing the work for quite some time. What brought me to this work is I'm in recovery myself. And about 2011, I started to get into emergency medicine, and I started learning more about harm reduction, and that's what brought me here. So thank you, guys.
Cool. Thank you. And Charlie?
Hi, I'm Charlie Nolan. I use he, him pronouns. I am the community health specialist with an organization called Savage Sisters. Been here for a few years at this point, a few years as a volunteer, and now a few years gainfully employed. I got into harm reduction. Originally, I was a recipient of services. I was a recipient of syringe exchange services and a recipient of overdose reversal medications. It just seems human to me. People treated me like a human at the time, and I remembered that. And I just want to do my best to make sure that we all get to feel like we're humans and part of society, regardless of choices we make.
Awesome. Thank you, Charlie. And someone I've known for quite some time whose birthday it is today, who's graciously joining us on it. Michael, please.
Hi, I'm Michael Lasday. I use they and them pronouns. I'm with South Philly Punks with Lunch. I've been with the group for a few years now. They've been around since 2020. We do mostly street-based outreach at a park and a street corner in South Philly. Um, and I originally got into harm reduction through involvement in nightlife and knowing some people in that community who had OD'd and passed away, and I'd been involved in kind of more general like social justice, direct action, movement building kind of stuff. Going back like since I was in high school and started to plug in with harm reduction folks in South Philly, and it really just seemed like the place that I should be at, and that's where I've been since.
Awesome. Thank you, Michael. And before we carry on, I also just want to say, like, this is not an infomercial for RiVive and harm reduction therapeutics. This is about compassionate overdose response. Like, these are the things I carry with me, and I respond differently based on if I witness something or I don't. And I'm very easy to reach. Anyone could ask me for more about that later. Reach out to me. because this isn't about me. So going to the next question, and I'm going to start with Charlie. What do you think compassionate overdose response looks like to you, like in real world practice and therapy, and therapy? Sorry, that's later today. And theory.
So it's a great question, and I think I can best highlight it by giving an example from my own life of what it's not. Um, my the very first time I overdosed, I had never heard of naloxone. It was available at the time. It was just wasn't something I was aware of, and there was a police response to my overdose. And I've since met the cop that did it, like met again later in life. And he told me how much naloxone was used on me. They used 4 injections, like the intramuscular injection of naloxone, and along with that, 2 4 milligram sprays. I still remember how terrible I felt. I felt like I wasn't alive, even though my life was saved, and I was breathing again. I was sure that I was brain damaged. I woke up to cops screaming in my face, "Where's the rest of the drugs?" And meanwhile, I like couldn't really hear, which I've since learned from other people is sometimes an experience people have when they first come out of an overdose. But I was like shell shocked essentially. And to me at the time, I was like, I would rather have just died than wake up and I've got cops screaming in my face wanting to know where my drugs are, and I don't know where I am and I don't know what's going on. So that I would say is like a hard line opposite to what our team and the other teams working in Philly try to provide for people. More naloxone's not better. It doesn't work faster. All it does is make people feel worse, from what I see and from what I've experienced. Compassion is just caring about the person that you're dealing with first and foremost, rather than like, let me load them up with as many milligrams as I can. I don't care what the effects are. I think you're muted, Van.
Sorry about that. And Michael, same question. What's compassionate overdose response look like to you in real world practice and theory?
I mean, I think it kind of just boils down to treating people how they'd want to be treated. I mean, a lot of times when you're doing OD response, you don't necessarily know how people want to be treated because you don't know them, but I think it's a pretty safe assumption that people don't want to be tortured. Um, and yeah, just doing yeah, an intervention with high dose, like it doesn't really help anything. Like the that's what cops do when they want to hurt somebody. Like it, you know, I'm sure people here have heard about this, that cops see somebody who's nodding out and they threaten to dose them and sometimes will, like as a form of punishment. And what, you know, on the other end of things, like if people are in a hospital setting and are being dosed with like medical fentanyl, they're on an IV, and if they should overdose, the amount that they're going to be getting through that IV is really minimal because it's just direct. It doesn't need to be much. And I've always just figured that anything that we're doing on the street, we should be trying to emulate that as closely as possible. Like I'll just say that, like, just in terms of what I carry, like we got South Philly Punks with Lunch, we got donated a bunch of these pre-fills with 2 milliliters in them that I just carry around like this, you know. Um, and I love that you can dial in exactly what you want to give somebody. Um, and would also like to point out that like the dosing that's available for intranasal in Europe, there's 1.26 milliliter, there's 1.8 milliliter. You know, we're a bigger is better country, so I think going from 4 to 3 is really great. Um, and yeah, it's yeah, I mean, just, you know, treating people how they'd want to be treated, and you know, the the better that people have an experience of coming back, the less hostile they're going to be when they wake up. The the less they're going to avoid being potentially around people who could help them in future scenarios, which is, something that I've had to try and work around myself.
Awesome. Thank you. And two things. One, when anesthesiologists overdose people, which they do all the time, the people they're overdosing in surgery, for a large part, are not opioid dependent. And they still use a more compassionate dose than we use for people on the street more often. So I wanted to thank you for that. And Carlos and Sean, how you and I've seen compassionate overdose with you in the street, where I've had the pleasure of doing outreach with you, Carlos, a couple of times. What's it looked like to you in real life, in theory and practice?
Prioritizing a person's overall well-being above actually seeing them wake up. There are times when someone comes to, um, they find out that they've been given higher doses of naloxone. They might be less likely to go to the hospital on their own afterwards.
Yeah. And also, one thing we need to remember is naloxone is just a tool that we have in our toolbox. And, when we're really talking about looking for threats to life, um, naloxone is more about restoring breathing than it is waking people up due to all the tranquilizers in the drug supply. So a lot of times when we find that there are no immediate threats to life, role in person recovery position, you know, uh, keeping them safe till the ambulance arrives. Might check some vital signs, make sure that we're breathing. But yeah, a lot of people out there are a lot in a rush to just give a person naloxone until they see it coming out their ear, it seems like. So, and a lot of people out there have told us that they felt like they were given naloxone when they felt like it wasn't needed. And that really sticks with the person. And, and we find some people and say, hey, you need some naloxone just to have on you. They're like, no, keep that stuff away from me. So, we like to put that compassionate spin on it. And when we really speak to people about it, educate people about it, about their different options, so many people are so interested in it and say, "Oh yeah, I'll definitely take that." So we've been distributing 3 milligram naloxone here for a little bit, um, and it's going really well.
Awesome. And I think what's really important is you had mentioned, like, prior, would say, before we had all of the additives like metatonazine and xylazine, people would give a dose and then the instructions were, and then tell the person what happened once they wake up. And people aren't waking up now. And I think we really need to, if anyone's on here listening and in your agencies are still saying, until they wake up, like, reach out to us. We can do a free compassionate training thing for your agency on Zoom for your staff. It's about restoring breathing. If the breath's been restored, the opioid overdose has been intervened with. And if someone's not waking up, what Sean just said, put them in the recovery position and just gauge them. If you're waiting for 911 to call, if you've called them, because also, like, overdose response doesn't need to be an emergency knee-jerk reaction. We deal with EpiPens all the time and have taken things like that out of the panic world. So thank you for bringing that up, Sean. How does your organization, or what's one persistent barrier you find for implementing a compassionate overdose response, and what's helped your organization work through it? And it could be something as simple as what I just said about people saying, like, you need to wake them up, or community response, or police saying we need more. Any of those things. Carlos, do you want to start this time? Carlos and Sean?
We try to take the opportunity during the emergency to explain what we're doing on live time. There may be people in the area who, if we humble ourselves, we are learning at the same time. But we just try to explain what we're doing, how long the naloxone would take to start working. Um, we're checking their vitals. We're seeing them breathe on their own. So we just try to relay that to folks who are around us at that time.
Yeah, and there's still a lot of misinformation out there, right? So about 10 years ago, um, fentanyl flooded the drug supply here in Kensington, and you know those that it didn't kill it made their tolerance go way up. So a lot of people still remember that, and especially when you have things like metonidine come into the mix and see people laid out all the time, that does invoke a lot of fear in the community. And so a lot of people, you know, great intentions, they want to help out, but a lot of people just haven't been updated in, some of the new science about
Yeah.
behind reversing overdoses in a compassionate way. Um, So we do our best to try to educate people, have conversations with people, because like Carlos was saying, we learn a lot from people out there and with our training and experience, that's how we develop our protocols and trainings.
Excellent. Thank you. And I think one really important thing for everyone is when someone might be dying in front of us, time does weird things. I've done hundreds of reversals. I've worked in SSP since 92. I was a New York City EMT for 16 years. This is your most powerful tool, and not for necessarily calling 911, because that's something, as someone who is an EMT, I rarely do. Um, but set a timer after you give someone a dose, because when someone might be dying in front of you, time does weird things. It speeds up, it stops, so I've had what felt like years pass, and I've looked at my timer, and it's been like a minute and a half. So thank you so much for that, guys. Charlie, um, same thing. And I know, and I've been with Sarah while she's done reversals on the street. Do you want to talk a little about titration for those who might not know? Because I think that's such an important key. And since we're not able to titrate nasally anymore, unless you have the 2 mil like Michael has, which isn't available for the general population, that's why we made a lower dose nasal. But you want to talk about titration with injectable?
Yeah, for sure. So I firm believer in using as low of a dose as necessary. What I tell in a lot of the like overdose reversal education that I do is the pulse oximeter is the most important tool I carry with me. Measuring oxygen is going to be the best way of telling, like, does this person need naloxone? Does this person need more naloxone? So what I and our team do, we actually preload our own syringes with naloxone. And we'll typically make our preloaded syringes smaller than one vial. One vial, the vials we use is 0.4 milligrams. We'll usually use about a third to a half, and kind of like slightly vary how much naloxone is in each one of our preloads. When we encounter someone overdosing or that we believe is overdosing in the field, put the pulse ox on their finger, get a reading. What we're looking for is oxygen below 80%, as like or oxygen that maybe is above 80%, but is persistently dropping, like it's in the process of going down. So what we'll do is we'll actually start with the smallest syringe that we have with us. And we'll give the person the IM injection, and then we'll monitor them for about 2 minutes. See, all right, as there's oxygen, while rescue breathing, of course, just giving them supplemental oxygen as best we can, or using like a mask with an ambu bag. Yep, exactly. And after about 2 minutes, like you said, setting a timer is a great thing to do because time dilates when someone might be dying in front of you. But monitor, like, okay, I've been helping them breathe, and it's been 2 minutes since the first dose in naloxone. Where's their oxygen at now? And kind of like as you get up to check their oxygen and like step away from helping this person breathe, you'll see that quickly if like their oxygen is stable or if it is dropping while you're not helping them breathe. And if it's still dropping or if it's still lower than we'd like to see, we'll give them another small dose and go back to the supplemental oxygen. And we'll kind of continue that cycle until until their breathing stabilizes, they're able to breathe on their own, at which point we roll them into the rescue position. And whether they become conscious or not, like we kind of stop there. Like they don't need more naloxone. Their oxygen's where it needs to be. They're not in danger of death. They're just unconscious. They're just sedated, and that's thanks to our toxic drug supply. So it's kind of like a inch and go is how I would describe it, I guess.
Van, you're muted. It looks like you're talking.
And Michael?
Yeah. I mean, thinking about barriers that we've had with this in the past, I think really the biggest change that I can think of that we've had is when we started offering IM like intramuscular instead of just intranasal. Like we didn't have RiVive at the time; it was just Narcan. And um, the way that our outreach is set up, we've got a line of tables that are clothing, food, living essentials, hygiene stuff, and then over at the end, we've got harm reduction stuff, some kind of tucked away at the end there. And so most of the people who are coming over and getting supplies from me, it's people who use drugs or people who are getting supplies for friends or loved ones. And when we only had Narcan, it wasn't that often that I'd get people who would be interested in taking a dose. Sometimes because they already had them on them, but I think a lot of times because people know what that kind of reversal experience is like, and they're not really that interested in being on whichever end of it, honestly. And my experience when we've had RiVive and also with IM is that people who would not be willing to take Narcan, finding out that there's a better option, like it's kind of funny that like we're in Philly, and I think people think about Philly as this like nexus of like the overdose crisis, nexus of like prohibition crisis, and like it is, but there's so much attention that's put on Kensington, and that kind of it's a triage that makes sense and should be happening, but it also means that 5 miles away in South Philly, most of the people that I'd talk to about intramuscular naloxone don't know that it exists. They know about Narcan. They're like, oh, they have an injection version now, when like, it's really the other way around. Um, and I think people just finding out that there are other ways of doing this has been really impactful. Like we have people um who come back and specifically ask for that, and like I can think of maybe, 2 or 3 times where that's happened with Narcan, that people just come up and are looking for that really specifically. But like yeah, just these are tools that people want, and I think putting focus on that, because there really are lots of people that are interested in better ways of doing this, makes a lot of sense.
Yeah. And it's interesting because we're such a needle phobic country that like in 98, I went with the United Nations AIDS Project to Moscow, and we helped open their first SSP. And when you're going to school, like your parents will give you your shots for school in the bathroom. Like there's syringes everywhere, so they don't have the same thing. So other places injectable isn't looked at with the same fear or disregard that we have here. Um, so thank you. And do you all run into any barriers, and I know I have, for teaching compassionate overdose response, be it titration or lower dose nasal? And the 2 mil atomizers that Michael brought up were what we used to have in the field. Um, and if you could hold that again, it's you'd screw in the naloxone vial, which looks like, thank you, which looks like either a vial of crack or a perfume sample, depending on your personal life experience.
So it's actually, I don't have the atomizer. This is a,
Oh, Sean has one. No, I know the
oh
pre-filled.
yeah, but yeah,
Yeah,
go ahead.
Sean, I'm sorry. Thank you, Sean. But like the thing that was great about them was you could titrate nasally because the instructions were put half up each nostril. And in Connecticut, EMS in Hartford still uses them because they can titrate, and EMTBs, like I am, can use them because we're not supposed to use needles. That's for paramedics. And now all EMS can use it in Hartford. And they found, since you can titrate, they're giving people 3.35 mils on the average, where lay people are doing 7.98. So it's a tremendous difference. So any barriers that you've run into, and we'll start with you, Michael, teaching compassionate overdose response with community members or doctors or nurses, who I often find are really misinformed because they get so little education about this, but we make them deities and they're expected to know everything. So any thoughts, Michael?
Um, what I was thinking about most for this is that I think the toughest sell that I come across is people who have usually as lay people or as like passersby um have done reversals, kind of using more of like uh conventional ideas about how to do this. They're carrying Narcan, they have Narcan at home, they run inside, they get it. They're maybe not aware of less being more in a lot of cases, and have somebody wake up that's really angry with them. And a lot of times, like there's, I can tell people about ways to do that where it's less likely for that to happen, but I think that that's really been the toughest thing for me to deal with. Like I'm not really dealing with um that many professionals with this work. It's mostly just, people who walk up. We're on the corner in Winter Park in South Philly. Um, but yeah, I think generally, even like if there's people that like if they haven't experienced that themselves, but they've heard about it or their friend did that, um, that's easier to overcome. But yeah, I'd say that's probably the toughest thing is people who've already had really bad experiences.
Charlie, same question, like any barriers you've run into teaching people in the community, and it could be anyone from drug users to like police or teachers or whatnot.
Yeah. So something that springs to mind right away is I'm really big on with today's drug supply, oxygen's the most important thing. Naloxone's great, always still use it. You might not always have access to it. You might not always have it on you. And helping someone breathe will buy them enough time. And with our dope supply having such a small amount of opioids in it anyway, like help a person breathe, get them oxygen. And just through conversations, whether it's at a training or a tabling event or during outreach of like, yeah, you gotta like give this person mouth to mouth because most people aren't carrying around an ambu bag or an oxygen tank or whatever. And there's just like the immediate reaction of like, ew, I don't want to put my mouth on a stranger's mouth. And it's like, okay, but like, do you want to watch someone die in front of you? So we've have success like giving out the little like plastic face shields with the cloth center, or part of our training is always like pull a person's shirt up over their mouth or pull your shirt up over their mouth or cup your hand between your mouth. Do something to create a barrier, but don't let being grossed out by going lip to lip with another human being
Mm-hmm.
stop you from like potentially saving their life. And it's hard for people, I think, like in my face when I'm in front of them explaining that to like argue against that. But I do think there's also like it's a very human reaction of like, I
Yeah.
don't know this person, or maybe I'm not close to this person. I don't want to get into that intimate like space with them being lip to lip. So kind of explaining that in a way that I guess makes it sound not gross and more human. is a barrier that we see in talking with people.
And it's so funny. I say this a lot. There's all of these, like, how do I put this graciously? There's all these kink and fetish websites that or apps that I'm sure many of us on this call are on. And I'm like, oh, you could do that with me, but I'm not going to put my mouth on you to save your life. That's where I draw the line. It's just so funny. And we've created such a fear of people who use drugs, which was compounded by COVID and the fact that all of these cops think they're overdosing from exposure, which they're not. They're talking about their heart rates racing, and that's a panic attack. Opioids slow your heart rate to the point we stop breathing. But these, just to say about these again, this is my infomercial for Ambibags. If you're doing outreach with a pair of people, these are great because it's really hard for some people to get a good seal with one person. And if you're alone, pull this right off. This is also great because one thing we don't talk about, fentanyl causes muscle rigidity. So if I need to deliver someone breaths and I can't open their jaw, their nose, and this will go right over their nose. Most of us are nose breathers on this call, I would venture to say. So, and same question, Carlos?
I was going to start this. Well, one thing I say, I haven't seen too many barriers in our neighborhood to implementing compassionate opioid overdose response. I think it's been welcomed in a lot of ways. But one thing, I do want to say, we always encourage people, get trained in CPR, get trained in first aid, because, most of the time it's very likely that a person with a high tolerance to fentanyl, they do a bag of train dope, it may not be enough fentanyl to cause them to have a opioid overdose due to their high tolerance, but it's enough animal tranquilizer to knock them out. In those cases, where it's not a true actual opioid overdose, their breathing, oxygen saturations are going to be normal or near normal. No threat to life for the most part, unless they're closing their own airway off or out in the middle of the street. But on the flip side, to be able to recognize when there's a threat to life and somebody is experiencing a life-threatening emergency, we're checking for life-threatening bleeding, making sure they have an open airway so they can breathe. If they're not breathing, we're breathing for them. If they don't have a pulse, we're doing CPR, having somebody grab the AED, and, I'll let somebody else give the naloxone. But at that point, when somebody is in cardiac arrest due to a known opioid overdose, they probably already haven't been breathing for more than 10 minutes, right? So, we'll let somebody else give naloxone. We're focused on high quality CPR. And I think it is essential to remember, again, naloxone is just a tool that we have in our toolbox. Our go-to is our experience and our training. And so I always encourage people, get trained, stay up to date on your certification, know the trends of the drug supply. Without drug checking, we wouldn't know about the xylazines or the metamidines or all the other stuff that's in it. Again, people in our neighborhood have been very welcoming for compassionate opioid overdose response.
Awesome, thank you. And back to what you said, it's so all about the breathing. I know a lot of places are trying to move away from breathing and talk about compressions. Compressions, first of all, if someone's heart's still beating, they don't need compressions. If they're still breathing at all, it means their heart is working. We don't need compressions. But I think that goes back to the fear of COVID and fentanyl risk exposure, which doesn't exist. That's going to circulate your blood for 2 minutes, which has oxygen in it. What happens after those 2 minutes? You're just pushing around unoxygenated blood. It's an effort and futility. There's a video Dan Big had made from the Chicago Recovery Alliance, who was the person who liberated naloxone and was giving it out illegally and helped get it into the hands of people who use drugs. And in, I think it was 2016, one of his coworkers had OD'd, and they reversed it while they were recording it and talking through it, and they were using injectable. And he said, if you're not giving rescue breaths, if someone's breathing is impaired, it's an effort and futility. It's all about the breathing. I breathed for people all night before we had access to naloxone in New York. And also since where I had actually this person on the shirt had OD'd in my apartment, and I know they'd been on and off different types of mat and often would do enough substances to override their blocker. And I knew if they were on at the time and I gave them naloxone, they'd be in hell. They'd be in precipitated withdrawal for the rest of the day and night. It would ruin both of our days. So I just breathed for them. Like, as long as someone is breathing, they're going to be fine, and the drugs are going to wear off and their breathing's going to increase. And that's really, and I don't suggest everyone do that level of care, because, it's scary and exhausting and all of that. So I just wanted to say that. And
Van,
yep.
before you go on to the next question, I know you answered this one in the Q&A already, but I want to read it out loud and read your answer because I think it's really important to emphasize and want to make sure everybody hears it, particularly because of the topic we've touched on a few times about adulterants, more and more adulterants in the supply. So the question is, I keep receiving information on quote unquote naloxone resistant drugs that include lidocaine. We know that if an opioid is present, then naloxone can work. However, the lidocaine might be impacting their ability to regain consciousness or other contaminants as well. How would you recommend updating the language and educating people on addressing these potential overdoses, especially because we want to respond in a correct and compassionate way? So your response was, if the breathing is restored, 12 to 20 breaths per minute, the opioid overdose has been intervened with. I think that's really important to emphasize. So just want to make sure everybody saw your response and give you and the panelists an opportunity to add on to that if you want to.
And I say intervened with really intentionally, because we've been using the word reversed for a long time. And when you reverse, you kind of back out of something, but we're not backing the substances out. Like naloxone lasts 30 to 90 minutes. So as it's wearing off, the drugs that are in your system are going to come back. So, we talk about, like, someone may overdose again. I've responded to hundreds of reversals, and I've had that happen twice. And that was like an extreme scenario. Put someone in the recovery position, watch them. If their breathing's restored, if someone's breathing 8 or less times a minute, if it sounds like they're snoring, those are signs of respiratory distress. That's their body saying, I need oxygen. If their color's off, if they're bluish, or if they're darker skinned, kind of ashen, or if it's someone and they just look off and their breathing doesn't sound right, supplemental breathing is it's all about breath. All the overdose prevention sites worldwide, the first course to action is medical grade oxygen. Naloxone is given secondarily, because the first thing we put on the pulse oximeter, because overdose is really an oxygen emergency in my belief. So we see the pulse ox. If you were in my ambulance as a patient, standard call to care, you would get 12 to 16 liters of medical grade oxygen through a non-rebreather, something like this that would have a hose on it. In an OPS, in an overdose prevention site, people start with 4 liters of oxygen through a non-rebreather, because it's not an oxygen emergency yet. And if their oxygen starts dipping, it'll bump up to about 6 liters, which is what you would use with a nasal cannula, still with a non-breather. So it's really all about breath. If the breathing is fine, the overdose, the opioid overdose, has been intervened with. And, if there are secondary concerns, that's when underlying health concerns, that's when I would call EMS.
And actually, that's a great lead into another question that just came in about calling EMS. And just a reminder for folks, please keep putting questions in the Q&A if you have them. We've had sort of a steady stream, but we didn't officially say that we were in the Q&A portion of the session, but we will continue reading them out and responding to them if you send them. So this question says, I know, Van, you mentioned being able to use your expertise as an EMT to avoid calling for emergency response or calling 911 in some situations. Do you recommend calling 911 for laypersons who may not have this sort of medical training? What considerations do you think are important for individuals to have in mind if they are calling 911 in an overdose emergency? It looks like Sean has a response too.
Yeah. And I'll just say, and then I'll let Sean chime in. I think the most important thing is time from incident to intervention, because that tells me so much. If I've come on someone and they're blue and not breathing, first thing I'm going to do is give them breath. because they're cyanotic. Their color's telling me they need oxygen first, and then I'll give them naloxone. That would be a good time to call if you're going to call. Also depends on your agency's policies. I know I ran a program in New York State where the Department of Health wanted me to call for every overdose. 911, I called 4 times in 5 years. And in all of my reports, which I reported every single one, and there were multiple ones a week, I would just say, like, New York State EMT 377-884 was on the scene and determined a higher level of medical care was not needed, because it often isn't if we intervene early. Sean, do you want to?
Yeah, thank you, man. So, our protocols is if somebody is unresponsive, so if I do a good sternal rub and they do not respond in any way, we're calling 911 and getting help on the way. And because we don't know, it might be something else other than an opioid overdose. It could be a medical condition that we're unable to see or unaware of. So we want to make sure that, we are looking out for that participant. We don't know everything that's going on with them. So to be on the safe side, if somebody is unresponsive, we're calling. And they can always, if they wake up, they can always refuse care.
Yep. Excellent. Cool. And the last question that I have for you all, what recommendation could you take back to or would you suggest for other organizations for supporting, like, trauma-informed care, destigmatization, and non-invasive approaches post-overdose? Michael, do you want to?
Yeah, I think and some of what I was mentioning earlier about people that are just adamantly opposed to this, just the advice that I had is that, uh, there are so many people out there, I think, that are looking for ways to do this that are going to actually reduce risk and reduce harm that I just don't think it's worth spending too much energy on people that are opposed to this. Like we've got so many people uh that are waiting for the material that we have, the information that we have to just focus on them and keep it moving.
Thank you so much. And I think, and I've been saying this for a long time, I do a lot of trainings. One of the things I think harm reductionists, or I know I have in the past, have expended energy on is getting you to believe what I want you to believe. And I don't care if you believe what I want, but I want you to get you to do what I want you to do. So I think, as opposed to trying to change people's minds, I'll like, especially with naloxone, Nancy Reagan, really, the whole just say no really drilled into people's brains that, like, this is a moral failing. And so you have to just, I can't support anything, which extends into administration of naloxone. And I talk a lot about the empty chairs. Like, if your family member or friend comes over just for the holidays, if they pass away, that chair is never going to be filled again. And you don't have to support their drug use to support their being alive. I support people's autonomy to do whatever they want with their bodies, but not everyone feels that way, and I don't need to get everyone to believe that way. I just want to make sure that we stop losing people who would otherwise be here. So thank you, Michael. Charlie, you're muted.
ADHD brain. So we're saying, like, basically what do we say to people that don't agree with us? Um, there's some minds that we're not going to change. My belief is that, like, open, honest education and conversations is the best way to change minds and, like, fight the stigma against people who use drugs. And it works on the people that are open. Some people's minds are made up, though, and I agree with what Michael was saying, that, like, I will put some energy into trying to change people's minds, but if people don't want their mind to be changed, that's fine. I'll talk to the next person. So at the end of the day, I know that there are plenty of effective people like Michael, like Carlos, like Sean, like our team that are doing the right thing and like pushing to against these stigmas that eventually society's mind will change and see that we've been right the whole time. But even when that day comes, we're not going to change every individual's mind, and we have to put our energy where it's most effective.
Thank you. And we, I believe, are at time, but Carlos and Sean, if you have any closing thoughts.
Just want to reiterate, we aren't going to be able to change everyone's minds, but I believe in the work we do as long as we're consistent. There are times when someone is coming to, and prior to them, prior to assisting them with an aftercare plan, we allow that person to know, hey, listen, this was the dose that you were given. When you present it, if someone's consistently being given higher doses, they may not return for our services. So when we're doing this street-based outreach, it's key that we are consistent in the work we do and those around us, and we might persuade some people in that manner.
Excellent. Thank you.
Thanks so much, everybody. This was really wonderful. I'll wrap us up because I know we're a little bit over time. I did put Van's email address in the chat a little bit ago. Van, when you offered that everybody could reach out to you. So if you have follow-up questions, feel free to send them. I learned a lot listening to everybody. I learned a lot reading through the feedback report and hearing what the community members who were interviewed had to say about all of this. So encourage all of you to take a look at the report as well, and hope that everybody on the call today will take back some recommendations from the panel and some thoughts to your teams about how we can work on closing some of these gaps around education, about what compassionate overdose response looks like, and access to a lot of the tools that were discussed today, including lower dose naloxone. So thank you all so much for being here. Thanks for your time, panelists. Thanks for moderating, Van, and hope you all have a great rest of your day. And happy birthday again, Michael.
Thank you.